So let's discuss about the Cushing syndrome. Cushing syndrome, the terminology used when all causes of Cushing syndrome, which include the central or peripheral, like adrenal and all. But when you talk about Cushing disease, we are specifically telling that it's because of the central cause, like pituitary adenoma, or like that. The most common cause of Cushing syndrome is iatrogenic, that the use of steroids, drugs, and after that it's pituitary adenoma. Okay, ACTH independent, the most common cause is of course adrenal adenoma. Most common cause of ectopic ACTH release causing the Cushing syndrome is from the small cell carcinoma of the lungs. Okay, coming to the clinical features, the earliest sign will be the weight gain that we see in the central weight gain, like obesity, and that causes the insulin resistance. Okay, and other symptoms like infections, patient might have fungal infections like tinea or even the candida infection. Other features, purple striae, easily which gets bruised, proximal myopathy will be there, osteoporosis, hypertension, that is diastolic hypertension will be there. Patient might also have psychosis, amenorrhea, and hirsutism. The investigation of choice here is 24-hour urine cortisol. Okay, and if the ACTH it is dependent, its ACTH levels are high, then you have to see for the tumor at MRI pituitary, and you have to do high dose dexamethasone suppression test. And the treatment of choice here is the surgery. Okay, and drug of choice, if you want to use the drugs, then we can use ketoconazole. And then there's something called Nelson syndrome you get when there is a bilateral adrenalectomy because of the increased ACTH. There's hyperpigmentation. It's called Nelson syndrome. Next, we'll see the approach which is given the Harrison. So suspected case, like clinical features are there, and then you suspect for Cushing syndrome. What we do is 24 hours urine-free cortisol, which should be 3 times more than the normal. Other tests like DEXA overnight test, in which we give 1 milligram of DEXA at 11 p.m. that is at night, and the early morning at 8 to 9 a.m. What you see serum cortisol levels, which will be more than 50. It's not suppressed by the DEXA. And also you can do midnight serum cortisol levels, which should be more than 5 nanomoles per liter. Okay, now to differentiate if it's central versus the peripheral cause, what you do is the serum ACTH levels. If it's more than 15, that means obviously it is from either center or ectopic. So in that case, when the ACTH levels are more, you do MRPT to rule out the adenoma. You do CRH test, that is corticotropic releasing hormone test, in which what we give IV CRH 100 micrograms, and then we see the ACTH. If it's increasing more than 40% at 15 to 30 minutes, and cortisol level increasing more than 20% at 45 to 60 minutes, then the test is positive. And also we have to do that high dose DEXA test, in which we give 2 milligrams of DEXA for 2 days, that is QID 6th hourly, and after that we see cortisol suppression. If it's more than 50%, then the test is positive. If this test comes positive, then the diagnosis becomes the Cushing's disease, and because of the pituitary adenoma, and then we have to do transperineal surgeries. And if these tests are negative, that means we have to suspect for ectopic ACTH. For that confirmation, what we can give is inferior petrosal sinus sampling you have to give, and you have to see the AC for the ACTH, and you have to see the ratio petrosal sampling with the serum if it's more than 2, and more than 3 if you are given the injection corticotropic releasing hormone, and at 2 to 5 minutes you see this ACTH levels. And then now if ACTH is less than 5, that means it's a peripheral cause, then you have to do the CT abdomen, that's CT adrenal glands. If it's bilateral urinary, based on that you decide adrenalectomy. So this is the approach. Thank you.